We have mapped many neuropsychiatric symptoms and disorders to brain networks, including depression, amnesia, so disorders of memory, anxiety, and epilepsy and seizures, but even more obscure and complex symptoms such as addiction or fundamentalism and these personality characteristics. So what one can do is when one measures before and after a certain perturbation in the brain, we can see the slight changes that happen in that behavior or in that symptom.
Generalized epilepsy is often described as when people have abnormal electrical activity causing a seizure beginning in both halves or hemispheres of the brain at the same time. But we have an interesting question here. Does seizure activity really start everywhere at the same time? Or could specific brain networks be involved, playing the game separately? Well, today we are joined by Dr. Frederic Schaper from the Center for Brain Circuit Therapeutics and Harvard Medical School, who is going to share with us how he and other researchers are mapping the brain networks involved in generalized epilepsy. And his work points to a key hub deep in the brain that may help explain to us why neuromodulation treatments like deep brain stimulation, or DBS, can work. If you're new here, please subscribe so that you don't miss our chats with global leaders in the spheres of epilepsy. And let's get into today's episode, presented in partnership with Easy by Persisys GmbH. So tell us, what is generalized epilepsy?
Epilepsy is classically subdivided into focal epilepsy and generalized epilepsy. Focal epilepsy is an epilepsy where we know exactly where the seizure is starting from, so it has a focus. With generalized epilepsy, we generally don't know. We don't know where exactly the seizure starts, and we think that it starts all across the brain, so a seizure of the entire brain.
When somebody says this, I think, oh my God, are you having like sudden activity in different places all at once? Surely it must start in one place first.
That's a great insight, and many researchers are focusing on that, including us. So generalized seizures definitely have a pattern. Exactly what that pattern is, we don't know. We think that in epilepsy, there's increasingly an involvement of brain networks. And what we do at the Center for Brain Circuit Therapeutics, where I work as faculty, is we try and map epilepsy onto brain networks, including generalized epilepsy. We use sources of information. That is either brain lesions or brain stimulation. These are both data sources that actually perturb the brain and therefore lead to a change in either behavior or lead to a symptom. What we do is we use these data sources to combine them with a human connectome, also known as a wiring diagram of the human brain, to see what circuits are involved in a certain disease, including epilepsy and seizures.
To give us a bit of insight into a broader picture, I guess, what other diseases benefit from this?
Yeah, so we've mapped many neuropsychiatric symptoms and disorders to brain networks, including depression, amnesia, so disorders of memory, anxiety, and epilepsy and seizures, but even more obscure and complex symptoms such as addiction or fundamentalism and these personality characteristics. So what one can do is when one measures before and after a certain perturbation in the brain, we can see the slight changes that happen in that behavior or in that symptom. And therefore, you can use these data sources such as lesions and brain stimulation in combination with a wiring diagram of the human brain to map these symptoms to brain networks.
So, excuse my ignorance here, maybe I'm making a silly presumption, but it kind of appears that because you can look at all of these symptoms, is there a connection between the symptoms?
We've definitely investigated that. So what we do is we map a symptom and then we see, is there any similarity between this symptom and other symptoms? And we've definitely seen similarities of symptoms that are actually comorbid with each other too. One including is depression and epilepsy. We've mapped certain focal epilepsies to brain networks, and we've also mapped using lesions depression onto brain networks. And we see definitely some commonalities there in their network location, which is in line with the high depression rate and high anxiety rate in patients with epilepsy.
So what about neurodegeneration in epilepsy? Because this is something that many patients are scared to talk about or ask, and also something that many clinicians are scared to talk about.
Yeah, neurodegeneration in epilepsy is far more common than we think. And What we know is not necessarily that we know that it acts as a neurodegenerative disease, but there's definitely studies that propose that. We've known most of it in temporal epilepsy and focal epilepsy, and what we are looking at is more delving into generalized epilepsy. What are the locations that are atrophied or hyperactive in patients with generalized epilepsy versus people that don't have generalized epilepsy? And there what we see is that the pattern of slight neurodegenerative changes, so atrophy in generalized epilepsy, is a consistent pattern that is published time and time again. And in our study, what we did is we tried and map those locations of atrophy to a brain network.
Tell us more about the study, how it took place, what were the outcomes, what did you learn, and any surprises?
So generalized epilepsy is usually considered a seizure of the whole brain. But there's increasingly studies that show that actually focal perturbations, such as the brain stimulation deep within the brain and the thalamus, kind of the control center of the brain, are able to stop generalized seizures. So those things contradict each other. The fact that it's a seizure of the whole brain, but that focal small perturbations can disrupt the seizure, right? So what we did is we thought to see, well, if generalized seizures are indeed amenable to focal perturbations, such as with deep brain stimulation, is there then a kind of key point, or is there a node that is kind of has a wider role in the network that is involved? And let's try and map that network. And to do that, we use these subtle brain abnormalities that happen in patients with generalized epilepsy to try and use them as data sources to find what is the network involved in generalized seizures. And could that be related to where we place deep brain stimulation electrodes? There are small neuroimaging changes, small brain abnormalities that happen. See these areas of atrophy where the cortex is slightly smaller compared to a person with the same age and sex. So these small clues, these small hints is what we use as potential traces of where the seizure either starts or travels to in the brain.
Interesting. So it's almost like it could look a little bit squished almost, or like a slight abnormality in shape, maybe. And it can be tiny, but sometimes it's not anything bad. It just looks funny.
So a patient with generalized epilepsy, by a clinician, they would say, brain is normal, right? We did an MRI. There's no brain lesion that could explain the seizures. Brain looks generally normal. But there's been huge neuroimaging studies worldwide. One of them is the Enigma study, where they had thousands of patients and compared them to a set of people with an MRI too, but with normal, a similar age and a similar sex. And there they see that there are consistent small imaging abnormalities that happen. And the step that we took is we tried and map these small abnormalities to brain networks and see if there was a common network involved.
And?
There was. So what we found was a consistent pattern. We saw a consistent pattern that kept popping up time and time again. And this was a small atrophy pattern in the sensory motor cortex, SMA, the thalamus, which is that control center of the brain, going into the cerebellum and also on other cortical lobes, so the outside of the brain. And that consistent pattern mapped to a common brain network. And what that means is that these patterns, where these atrophy abnormalities fall, they fall in a common network, in a brain network. And that brain network is the network that is involved in motor control and loss of consciousness. So these two networks are kind of the yin and yang of the seizure network, that kind of determine and explain where these brain abnormalities happen.
Was that a surprise? Was that what you expected?
It was a surprise that there was a common network involved, because one thinks that every epilepsy patient is different, every subtype and seizure, such as myoclonic seizures, absence seizures, generalized tonic-clonic seizures, are different. And they definitely are different, and different patients are different too. So there's definitely things that distinguish patients and epilepsy subtypes from another. But that doesn't preclude the possibility that there's also networks that are common between them. I think both are true. There are both networks that are common between patients and networks that are specific to patients and subtypes. What we mapped in this paper here is the network that is common across different patients and subtypes with generalized epilepsy. And when doing that, there is, of course, the promise that this network may be a target, a potential brain stimulation or neuromodulation target to try and treat multiple epilepsies. epilepsies. And that is kind of what we did here. And what we found that really shocked us was when we really looked deeper into the specific nodes of this generalized epilepsy network, is that the number one peak in the whole brain was the thalamus, the central thalamus, which is exactly the location where neurosurgeons place their deep brain stimulation electrodes to treat generalized seizures.
Before we move on, with thanks to Easy by Prosthesis GmbH. What are the next steps then for you regarding this? Because this is exciting. I've got all these ideas going through my own head, but tell us what your imminent plans are.
Well, I'm of course happy to hear that you're excited. I am too. Our plans are, what we don't know yet, of course, is whether this network that we identify that unifies different generalized epilepsies, if this network is a safe target for neuromodulation, an effective target, and if it's a effective target for every subtype of generalized epilepsy. So on the future realm, on the research level, we are very interested to work together with other collaborators, and we are doing so currently, and would invite anyone that is interested in this topic too to reach out to map using patient-specific data and replicate this network again, and then also look into the specific patient-specific atrophy patterns and subtype-specific atrophy patterns. So we at least know what are the networks that are common between patients and what are the networks that are different between patients. And that will inform our next step onto therapy. And onto therapy, what we need to do is design new clinical trials to try and modulate this network, either invasively with deep brain stimulation or responsive neurostimulation, or modulate this network with non-invasive brain stimulation, such as transcranial magnetic stimulation or electric stimulation. So this brings us to an important question of where does neuromodulation belong in the treatment sequence, in the paradigm of how we treat a patient with drug-resistant epilepsy. And currently where it's at the point where it's after surgery. So if a patient has been deemed to not be suitable for epilepsy surgery for their focal onset epilepsy, or if the patient opts out of surgery, then neuromodulation will be offered. And that can be in the form of deep brain stimulation or responsive neurostimulation. What we always tell patients is that neuromodulation can reduce seizures, but we don't have hard evidence yet that it can lead to seizure freedom. So it can reduce the frequency and the severity of seizures. One thing is why we still always offer surgery to and not place neuromodulation before the surgery treatment paradigm is that epilepsy surgery in around 60-70%, depending on what patient specifically it is being performed in, can lead to seizure freedom. So it can lead to seizure freedom in up to 70% of patients in the first 1 to 2 years. So that is why we don't place neuromodulation yet before surgery. But it's increasingly being considered at an earlier stage. And by patients, it's also increasingly considered as a viable option, because we also know that surgery doesn't always lead to seizure freedom. It can lead to a seizure reduction or a reduction in seizure frequency and severity.
Was there anything in your paper regarding the psychiatric morbidities or symptoms of epilepsy and how they can be minimized potentially in the future? So
this paper focused on seizure brain stimulation and on atrophy in generalized epilepsy in general, but we know that, of course, epilepsy is not just seizures. So in this paper, we were not able to focus on other symptoms of epilepsy, such as depressive symptoms or anxiety, or at a larger message on quality of life. And I think where definitely an opportunity lies is to really try and improve quality of life and measure those in future and current trials of epilepsy to see what are the networks or what are the main determinants of an improvement of quality of life after deep brain stimulation, or in epilepsy and generalized epilepsy in general.
I think it's important to say and reassure people that even though, for instance, this paper doesn't specifically look at that, the research that you've done and are doing, and the same for others as well, is long-term looking at improving quality of life. And we need to have this data in order to achieve that long-term.
Yeah, 100%. So what we do at the Center for Brain Circuit Therapeutics here is we try and map neuropsychiatric symptoms to brain networks. And that spans across epilepsy. That includes depression, anxiety, amnesia, disorders of memory, etc. So our goal at the center is to improve the burden to people with neuropsychiatric disease and improve their life by mapping and targeting and modulating brain networks. So we do that for patients with depression, anxiety, and epilepsy. And our dream is that at some point, these networks will inform our treatment in either disease, so that a patient with epilepsy and depressive symptoms can benefit from neuromodulation to targets either identified in patients with depression or patients with epilepsy. And that is our, I think, ultimate overarching goal.
Or those with both, 2 in 1.
Definitely. So also the patients that have depression and might have seizures, which usually is an exclusion criteria for TMS treatment. So getting to know more about those patients will also help us treat those people that have both depression and epilepsy. I just want to thank you, and I want to thank all of the patients that openly share their information and their data with clinicians to perform scientific research. This is very, very important and allows us to make these serendipitous findings, such as with this generalized epilepsy paper, where we saw that a network includes the locations that are being targeted with brain stimulation. If patients would not have given their data to be available for this type of research, we were not able to do it. So I want to thank patients and thank researchers that share their data too.
Thank you so much to Fred for sharing his cool, exciting research, highlighting how combining large neuroimaging data sets with brain stimulation research might help identify the networks involved in generalized epilepsy. Understanding these networks could help guide future therapies, including neuromodulation approaches designed to target the individual circuits involved in seizures and potentially improve outcomes for people living with an epilepsy. Again, huge thanks to Easy by Prosthesis GmbH for partnering with us at Epilepsy Sparks.